Good evening, Dr. Ruth.
Good evening, Nory.
How are you doing today?
I'm very well, thank you very much. It's not such a hot day here in England today, so I'm better in cooler weather. So it's been a good day, but I've been hard at work preparing for you for this evening.
And I'm sure that we are all going to be fascinated of what you are going to present today. First of all, let me introduce you one more time for those people who didn't attend the first part of our seminar. This is Dr. Ruth Brady. She is a facial aesthetic clinician and a multi-winning award for 7 times. She has been qualified as a dental surgeon in 1981, but she is now focusing on advanced facial aesthetics using a non-surgical means. Dr. Ruth have managed to create a well-established name for herself in UK. And actually, when I invited her today, and the last time also, to give us this webinar, she was a very kind and lovely lady and managed to give us a little more of her time to indulge us with such with her beautiful work. I'm gonna speak in Arabic right now for a few moments. مساء النور ورمضان كريم على كل الدكاترة اللي بيحضرونا النهارده. أتمنى أن تكونوا بخير. لو انتم ما شفتوش الجزء اللي فات افتحوا الفيديو سيكشنز عندي في الفيسبوك بيج بتاعتي، هتشوفوا البارت 1 من الويبينار اللي عملته مع دكتور روث بريدي. النهارده هيبقى الجزء الثاني هنعمله بسلايد شو برزنتيشن. دكتور روث عندها خبره كبيره جدا في مجال التجميل. انا ذات نفسي بتعلم منها واستفدت منها كتير جدا، اتمنى ان انتم كمان تستفادوا منها. تابعوني. وبرضو احب اشكر ديفن مارك فور ماركتنج اند اورجانيزيشن ودكتور مينا كامل على ان هم التنظيم اللي عملوه والدعايه اللي عملوها للويبينار بحيث ان يجيب كميه مشاهده كويسه، وعلى المجهود الرائع اللي هم عملوه. احنا هنبتدي النهارده. لو اي حد عنده اي اسئله يكتبها بس على جنب، ودكتور روث هترد عليها في اخر المحاضره، لان انا مش عايز اعمل لها اي نوع من الانتربشن خلال الويبينار اللي هي هتقدم. Dr. Ruth, are you ready for showing us your presentation?
I am, and if I may just say to my English or my UK counterparts over here, hi everyone, and Dr. Nory is a very passionate oral and maxillofacial surgeon. We've had a great chemistry between us. The presentation didn't come up. We had a technical issue last time, so we've actually turned this round, and this is part 2. And I was highly impressed with his knowledge, his passion, and I feel like I've met somebody across the water in the Middle East who really does see things in the same way that I do, and it's lovely to be invited by you onto this live webinar tonight. Thank you.
Thank you so much, Dr. Ruth, for those nice and sweet words of yours. It's actually a great honor for me to hear such a beautiful compliment from you. Now I'm going to give you the mic. I'm not going to interrupt you at all during your presentation. You are all alone on the stage right now.
Okay, well, I'll put the main screen on, then I won't be able to see you. If there's a sound problem, please interrupt and let me know. But if I don't hear from you, I'll take it that everything is working okay.
Okay, Dr. Ruth.
Here we go. Here we go.
You can start with the presentation.
This is me, Dr. Ruth. I've been doing advanced facial aesthetics since 2004. I was doing dentistry at the time, and I was just really a little bit more forward thinking, I think, in the sense that I realized that this was another slant to dentistry in a way that I'm going to show you tonight. I'm lucky enough to, I had my own practice in Yorkshire for 30 odd years with my husband, and I sold it, and I thought I might retire and moved up to North Yorkshire, which is a gorgeous county in England. We call it God's own county. Anyway, I settled finally, after moving practices a couple of times, into this wonderful practice near York, where I am surrounded by the most wonderful team of people, clinicians, and my colleague Linda Ullman, who is a great support, and my practice manager, Tracy. She's wonderful. I'm also an instructor with Sabrina Shah Desai, who is an oculofacial plastic surgeon. And we do, this is Sabrina right here. This is me here. And another of the faculty members here. And we do this several times a year on cadavers, and we are actually taking doctors, dentists, other surgeons, and nurses. We're teaching them the finer points of cadaver facial dissection, which I think is invaluable. But I'm going to come to this later on, because I'm going to show you a few I also do what's happening in people's practices. I think this is absolutely valuable. This demand showed itself a couple of years ago. And one of my pupils was my daughter, actually, Rebecca. She's been doing very well, and this is just a picture of her and me, and I'll show you a little of her work later. In fact, this is just an example of 2 pairs of lips on her second session with me, immediately post-op. There is the cannula entry point. There is no bruising, virtually no swelling. The title of my presentation tonight is Let's Face It. It's a play on words in England. Expanding the Frontiers of Dentistry. Facial aesthetics is now an accepted discipline within aesthetic dentistry, because some of the awards that I won were within aesthetic dentistry. That to me proves that it is now in the realm of dentistry. So what is facial aesthetics? It's a specialty that deals with the form and balance of the face to give a more pleasing appearance, and it encompasses the way that the tissues of the face and the neck age. So, because a lot of my audience tonight are in the dental field, and this was why Nory invited me in the first place to speak, was to show how I felt that dentists had a very valuable part to play in facial aesthetics. So I'm going to show you the relevance. First of all, I believe that the teeth are the picture. We've all been treating the teeth for so many years. More and more these days, people are wanting whiter and straighter teeth. They're wanting the teeth of a young person, even though they may be older. The problem with this is that if they've got young teeth and an older face, the teeth look fake. So if we can do something to the frame, which is the rest of the teeth, the rest of the face, the lips and perioral tissues, then we can make them look as if they were born at the same time. I consider the frame to be both an inner frame, that was where we used to just limit our work to, the lips and the perioral area, but we've gone a lot further than that now with advanced facial aesthetics. And I now call the rest of the face the outer frame. And we look at profiles, and we look at the whole face. These days, I actually, my own term now, instead of advanced facial aesthetics, which is a term that I think encompasses all sorts of things, I tend to call it surgical plastic. It's akin to plastic surgery without the surgery and without the downtime. It's almost an immediate result, and if you're careful with it, You don't even leave a mark behind, let alone a bruise. Relevance to dentistry. I have a few written slides here before I move on to photographs of before and afters. I'm speaking quite clearly, I hope, because I'm very mindful of the fact that people in the Middle East, this is not their first language. People in the UK, speaking people as well. Please bear with me. So we have the improvement of the aesthetic of the immediate frame. We've got treatment of the gummy smile and incompetent lips. We have treatment of the temporomandibular joint and the treatment of orofacial pain and headaches. The reduction of the masticatory forces and bruxism, and that involves the study of occlusion. And then we've got orthodontic enhancement, which is really profile enhancement with gummy smile and incompetent lips. So the relevance to restorative dentistry, we have lip stabilization, again, treatment of the gummy smile, treatment of incompetent lips, they often go hand in hand. Improvement of the inner frame, the lips and perioral tissues, treatment of the jaw joint, headaches, and reduction of the masticatory force and the bruxism habits. There's a relevance to prosthetics. You've got the restoration of tissue volume of the perioral tissues, the improvement of the perioral skin, the improvement of the lip volume and shape, and the improvement of the chin projection. All of these, when you're coming to do dentures for patients, this is very important. So the relevance of occlusion and parafunction, which is something only dentists will understand, this is where we involve the treatment of the TMJ joint and all the muscle problems. And we've got the reduction of the biting forces and the grinding and clenching habits, which is bruxism, which cause so many dental problems. And finally, the relevance to orthodontics with the incompetent lips. Again, the gummy smile, trying to treat the short upper lip and the maxillary vertical excess. Jaw discrepancies, we can mask the class 2 and 3 by soft tissue augmentation. We can balance the profile with nose, chins, premaxilla and lips. And we can improve the perception of the Kefler-metric angles, all of which orthodontists will understand. I'm going to show examples of all these things shortly. Relevance to orthodontics, we've got noses, lips, chins, nasolabial angles, and the mentolabial angle here, and the nasolabial angle there. So in practice, really, advanced facial aesthetics encompasses, I've spelt that wrong, there should be an A there, that's the American way. The full face and neck aesthetic approach, we enhance and we restore. We've got the jaw joints, we've got the clenching and grinding, the tension headaches, and we also deal with sweating, perspiring. And why is it finally useful to have a dental background? Well, and not just a surgical background. This is not a surgical subject. We have the knowledge of the structure of the jaws and teeth as dentists. We know about the support that they provide the soft tissues of the face. We have experience from day one in facial analysis. We have detailed knowledge of the anatomy of the head and neck, but in fact, we need to make that far more detailed by doing cadaver dissection on heads. And we have fine injection skills. We have been using syringes since the day we first went into second year dental school. But it's also important to have an aesthetic eye. A dentist that doesn't have an aesthetic eye would not be any good doing facial aesthetics. We have to have an artistic flair. You can see a dentist, you see dentists, you see patients who have dreadful porcelain work, dreadful crowns. They look false. You can see the margins. You know that the work is not natural. But there are dentists who do it so well that you don't even know that the teeth aren't the patient's own. And that's the best approach with facial aesthetics. We need an understanding of the aging process. We need to know where the tissues come from if we're going to put them back in the right place. We don't want to create an unnatural look. I need not tell you that these are not my cases. You'll see these in the press. Sylvester Stallone's mother, and I don't know who this young lady is, but to my way of looking at things, this does not look natural. It may be, some people like it. And obviously this young lady did like the look, and perhaps her friends did, but this is not for me. We don't want animalistic distortions. I think sometimes there's a psychiatric problem behind this, but there's a clinician who has done this as well as a patient who has requested it. And I think it is very sad. And I want to dispel the myths that all dermal fillers have to produce this type of outcome. It's not true. We want a natural harmony with the face, just as dentists want to produce a natural harmony with the teeth, with the restorations within the mouth that look as if the teeth have just grown in that beautiful form. And I'm now going to present to you, I was lucky enough to get working with me recently, about a year ago, when I moved to this new practice at Acombe near York, the most wonderful nurse. And she has given me the permission to show her case, which we did in 2 stages, but most of it was done in 1 day. I had a representative from the Northwest manager from Teoxane sitting in with me and assisting me, and we had a wonderful afternoon, and these are the results. I hope you like what you see. So it's a full face transformation. This is what I augmented. I did her cheek, her cheeks, her tear troughs. I did her chin, her jawline, her perioral area, and I augmented her lips. When we do things like this, I do believe in placing the product very precisely at the right depths, various depths, but I call it precision aesthetics or non-surgical plastics. And this is the primary toolbox that I happen to use in this case from Teoxane. They are fantastic materials. They blend into place. I like to put them where they are wanting to stay anyway, but the way they mold within my fingers is fantastic. I use the Restylane range as well for many things and have done for many years, but I've been in the last year introduced to this range, and it's just amazing to use. So I can use both Restylane and which is Galderma and Teoxane, but I like them both. But Teoxane really has worked very well for me in many cases now, and this is what we used in this case. Immediate before and after photos, and there was, apart from one tiny little entry needle, what Nory calls the pilot needle, entry point, which we had a little bleed on, there was no visible bruising or swelling really. This is Karen beforehand. She was a little bit worried by her chin to start with, and mentioned it to me, and her gummy smile. And what we did was we did a full consultation and we did a facial analysis. She'd seen me work on other patients, so she had no fear. She knew it wasn't going to be painful. And she asked me whether I could do a little something for her. And she is so wonderful. I said it would be my pleasure. That was her 3 hours later. I started at 12 o'clock with Bill Lewis from Teoxane sitting next to me, and that was taken 3 hours later at 3 o'clock. I did a treatment plan. This is what I decided to do. I wanted to enhance her cheeks. I wanted to do her tear trough. I wanted to bring this perioral area and the lips forward to give us a better angle here. And I wanted to augment the chin. And I wanted to structure the jawline. And this is the sort of look that I planned. So this was her beforehand, and you can see how this plan relates to her appearance. This is what we wanted, and this is what we got. You can see right here that we have got a better labiomental angle, a better nasolabial angle. We've got a lack of tear trough, a better shadow under the cheeks, which I understand we like here in the UK and Ireland. It's very Irish bone structure. I understand that in the Middle East, less of a shadow, but you will see it soften off in a few pictures' time, which are taken after the event. So there she is to start with, and there she is afterwards. And we got exactly what we planned. And I just finally, from the front, I'm going to fine off her nose just a little bit more, but we haven't actually got round to do that. But her nose is beautiful. She is now a stunning lady. She was beautiful before, but my goodness me, she really is getting so many compliments now. So look at this lovely shadow that we've got here now, and this lovely shadow. And this is a lot better placed than it was before. She looked more tired. So here we are, a half profile, the planned appearance, before and after. And now this from the front view. You can see how the mentalis muscle is having to be contracted to close these lips together because the chin is small. So she's got an awful lot of stretch to put the curtains together. If you watched part one, you would realize what I was talking about. Even my mother, who watched afterwards, understood this. She's having to put a lot of contraction in order to hide the teeth, to keep the mouth closed. But you can see she's very flat in the face here. There's no apex, and there's quite, it's not really a tear trough, but she looks more tired. And that was 3 hours afterwards. This is slightly overbuilt at the moment because we know it's going to settle just here, and you will see photos. Her lips are going to take more stages. I've had to do 2 stages here, and it's going to take a third in order to get the right stretch to the shape that I want. Lips are not always corrected in the first session. A little bit of prescription toxin has been used here to give her some nice eyebrow lift. and to calm any crow's feet down. So that was before. And this is afterwards. And you can see it's like topography. Here the face is very flat and slopes away. Here we've got a lot more interest both laterally and on the frontal angle. And we've got shadows. We need shadows on the face. Otherwise the face becomes too flat. That's okay for people from the East. That is how their faces are designed. But here in the West, we expect to have more shadowing. That's just from another OG curve, which you can see from this angle. So we've got a very flat cheek here, very flat there. We want more of a curve, an OG curve, and it gives the face a much more beautiful view when looked at from the half profile, which is really the most beautiful angle that you can look at a patient's face. So you've got this beautiful curvature and this lovely curvature here, but look at the interest in the chin. If you see how the chin slopes away, now you can see how we have the cheek curve, and then we've got that beautiful curve coming here to the chin, and actually we have a better jawline. That was the pilot needle, the entry needle, which made a little bruise. That was the only bruise that she had. But there's a lack of jawline here, and we've got a better jawline there. And then finally, on this position, the profile again, you can see the change and the better jawline. We didn't want to make it overly strong, but you can see the angle there. So I do the planned appearance again, the treatment plan, the planned appearance. You can see the jawline better here. And then finally, the before with the lack of jawline, the better jawline here. The angles are different, better angle here. The lips are brought forward. We're nearer to Steiner's line, which comes, we've got on Steiner's line, we've got the lower lip kissing the line and the upper lip setting just back from the line or in contact, just kissing, which is what we want. And altogether, a much more attractive profile. And I've used Teoxane Ultra Deep under the muscle in the chin. I've used RHA2 periorally. I've used Kiss in the lips, specially designed for the lips. And then I've used RHA4 deep on the periosteum, underneath the sooth, under the muscle, on the cheek, at the apex and backwards. And I've used Redensity 2, which is the only one that is actually properly licensed for the tear trough area. And then we've used RHA4, which is a beautiful molded material in a linear fashion along here, just missing out where the jowl region is. And this just molds so beautifully into place that you don't feel it, but you can see the support. What you didn't see on those photos, because she wasn't smiling, this was Karen's smile beforehand. And she's always very smiley, and that was a very natural smile. I've calmed that smile down now. We have used a toxin, a prescriptive toxin, to calm the muscles, the negative muscles in the upper face, so she has no crow's feet. It's helped bunch this lower eyelid beautifully. She's got this nice cheek squeeze. And then we've calmed the upper lip. She's showing less gum, which she has a slightly sloping line to the teeth. The actual gingival line is on a bit of a slope, a bit of a canter. but this is the amount that in the Western world we would expect to see. In Russia, I believe it's not none. Some Black African countries, they should show a lot more gum normally, but this is how in the UK we perceive a better smile to be. And that's from another angle. She's a very, very happy lady. She's such a beautiful girl. She's got the most beautiful profile. And then, after Christmas, we did a little bit more, just to tweak the enhancements because they'd settled. And so this was in March, just before lockdown. And you can see how things have settled very nicely. They're a little bit softer. So to the Middle East patients, they'd probably find that this was more acceptable to how they like it. That is her. I can't tell you how happy it makes me feel to sit next to this young lady and have her looking at me like that. She's taken on quite a cheeky expression, and she makes me laugh. We have a lot of fun working together, but my husband just loves this picture. He just thinks she's so beautiful. And what this enhancement has done to her it's made you focus on her eyes. And I would say that she's got probably the most beautiful pair of eyes I've ever probably seen on a woman. And you just notice those now because everything else looks correct. And that is her. So some more cases. We do anti-wrinkle treatments. We use dermal fillers and we use prescription drugs. There are some that we're not allowed to advertise now in the UK, but this is where we have used a toxin treatment as a preventative method. This is actually on my daughter when she was about 27, and I just keep this up now so that she it calms down her crow's feet. This was another lovely nurse that I had who had to move away, and you can see here the bunching of the tissues and the brow that's down, and we've given her a slightly more tilted up, laterally tilted brow, which has opened up the eyelid show and opened up the eye completely and softened those crow's feet and given her a little bit of cheek squeeze. And another lovely colleague, again, who, bunching of the eyes, you can't see much scleral show, but here you can. And so it gives her a wider-eyed look. And this was my dental nurse before, and she can't use makeup, and just use of a prescription toxin, I've managed to calm the negative muscles down, open the eyes, and give her a much more fresh look. So, what are the lips? They are a frame to the teeth, we all know that, but they're also a tool of expression. The lips are very, very important. If you don't get the lips looking right, when you've got a nice set of teeth or you've just restored the teeth, you will not enhance the teeth. The frame itself will let down the picture, and vice versa too, the other way round. If you've got beautiful lips, you've got a beautiful frame, but the picture isn't so good, then one lets the other down. So they do go hand in hand. Younger lips, we tend to look at proportions of 1 to 1.6. But this is the ideal. And some people may not think it's the ideal. Some people think 1 to 1. We tend to think 1 to 1 for a man, but it's different in different cultures. And I tend to try and like to go for the 1 to 1.6, but it's not always possible. And this is a case where I virtually did. In fact, it's a very similar lipstick too, but that's just a finished case to show how we have achieved that. This is a gummy smile and incompetent lips. Too much gum show, too much alveolar bone showing. The lips are a little thin. What we've used is a toxin, a neurotoxin on prescription to stabilize this lip, the upper lip, and then we have enhanced with dermal filler. This was Restylane Kiss in the lips to give that more natural smile. This was the patient with her lips closed. She couldn't close them except if she was to contract the mentalis muscle and the orbicularis oris muscle, and then she could close them. So just relaxed closed, that is how she is. This is now relaxed closed. I have secured, I have stabilized the upper lip, and I have put some more curtain material in the curtains so that the curtains close across the window. This is the window, these are the curtains. They close easily, effortlessly. This was my daughter a few years ago. She was actually already getting quite thin lips. And of course, I have enhanced her and I've given her a better texture to the lips as well. This is a young girl who had nice lips. But like many young girls today, their friends go and ruin themselves by going to clinics, sometimes beauticians, people that shouldn't be doing lip enhancements, and they ruin them. So her mother brought it to me and said, if you don't do something just to enhance them a little, she'll go to these other places. So I did a gentle enhancement, and that was immediately afterwards. This is where we entered, a little hole just there. And I tried to build up the central bit to give it a little bit more. So there'll be a little bit of swelling here. They settled down a little more from this, but there was no bruising, and this is where we entered. And she's got a lovely little Cupid's bow just here. This is my daughter again. And this was the second time I ever taught her in a one-to-one session. That was where she entered, here and here. And this was taken immediately as she had finished the patients. It's two different patients, as you can see. And she's given a nice roll on these lips. This is a lady who's partly got Caribbean blood in her, so she can afford to have more voluptuous lips. And this is a Caucasian European lady who wanted to have more voluptuous lips. But I was very proud of her. This is what the one-to-one teaching can achieve. Older lips need several treatments, and there are other concerns such as the perioral lines and folds. Although this patient hasn't got much in the way of the perioral lines to show you, I'm just showing you how we have got a better shadow and a better form altogether, where they were starting to go flat. This patient is about 45. And this lady was actually in her 60s. She'd lost her Cupid's bow. She was flattening off here. And we've given the most beautiful pick, rosebud lips. But that was after a couple of sessions. So I believe in the drawstring bag. This is what happens when you purse the lips. The lips roll in, they flatten, and we lose the fat around the mouth, and the skin lies directly on top of the muscle. And when the muscle contracts, the skin is thrown into fold. And this is basically what's happening. As the lips get smaller, the drawstring bag draws in, and the material around the bag starts to pleat up, and the patient hates this. Of course, smoking enhances this, it speeds it up, and so do habits such as sucking on straws. And this is somebody whose lips are starting to age, and we've got the pull of the angular oris muscle, the depressor angular oris muscle, dragging the mouth down in a habitual way of speaking and expressing herself. And this starts to cause the mouth to slip downwards, and with the pressure of the descending tissues from the cheeks, we get the look that we call sad mouth. Treatment needs to be multifactorial. We need to restore volume and collagen, strengthen the border to resist the effect of the pursing action. We need to restore the shape and projection. We need to weaken that orbicularis muscle around the mouth. We need to weaken the depressor angular oris. And we need to rejuvenate the surrounding tissues and plump them, hydrate them, and strengthen them, produce more collagen. And we can lift and expose inturned corners and restore the width of the mouth as well, of the chin projection. If you don't get the chin projection right, you are not free to do what you want with the lips. The dentition, are they lacking support? Do they have dentures? Is it a new set of dentures that's required? Or is it that they need their lips enhancing? It could well be in the older population, dentures are required. They're too old, they're lacking support. They may have a two-position problem that is not supporting the lips. We may have worn teeth due to bruxism, grinding and clenching, well, grinding, and we may have overclosure because the teeth are flattened off too much. And if you have overclosure, you'll never, ever bring the lips back to the sort of form that you want them to, despite however much you try. This is just a typical case of worn teeth. And this, it may be a joke picture, a bit to the extreme. This was one of our comedians in this country. He's now dead, but he used to do this gurning on his show. But this is what I mean, to an extreme. If you have very flat teeth or you've lost your teeth, your chin can come too close to your nose. You will never restore the lips in the correct way. So you can do it with one increment only. I personally believe that you cannot get that perfect result on somebody who is a little bit older or a young person who doesn't have well-developed lips. So sometimes you can do it in one, and sometimes you have to do it in more stages. But if we're talking about older lips at the moment, I would say that it requires more than one. And you will need to do something with the surrounding skin, the perioral lines, the nasolabial folds, the marionette folds, chin projection possibly, and the dimpled mentalis muscle. And I use the Brady buttering technique. 2 increments produces more collagen, gives you better shape, and a more long-lasting shape. And the perioral just become firmer and smoother. But look what can be achieved with 3 increments. We get a beautiful shape, projection, and often perfect proportions. We get firmer and smoother tissues around the mouth, which are more resistant to creasing. And I'll just come back to this case again. I'm sometimes limited by the patients that I can show. Some patients do not want showing on screen. But this was done in 3 increments. It took 3 different treatments to get this patient into this beautiful look from where she was before. And the same, it was 2 with this lady. If I'd done it all in one, I would have made her look outrageous in one go, and all her friends would have laughed at her, and her husband would have reprimanded her, I am absolutely sure. So do it incrementally, and I would say that often it cannot be done in one session. I'm going to show you examples of nasolabial lines and folds, and I've used the Brady buttering technique, which we talked about last time. If you look at the typical fold from the descending cheek and hypertrophy of fat, we can smooth these off completely. This is untouched photography. Or we can soften them. We can't always get rid of everything, but I have other little tricks that I learned from a chap called Tom Van Eyck for finding out these fine lines here afterwards, but this was done by buttering. Cheeks represent youth. The height and the fullness. This is obviously a young person, but you can't see the rest of the face. But you know that it's a young person because of the cheek structure and this lovely OG curve. We shade these with makeup. Nory was just telling me about the power of using makeup, and should he be actually starting to teach people how to shade things? And I agree with him. It's what female facial estheticians like myself would possibly be interested in, and I think it's a very good idea. This is a lady from the Middle East, and actually I'm allowed to show this part of her face without giving her identity, but we did her chin, we did her gummy smile, we stabilized her lip, we made her lips fuller in more balance, and we did her cheek enhancement, and she looks beautiful. This was Karen, my nurse, just focusing on her cheeks. This was immediately post-op. I had actually gone in from the side, and I'd gone in from below to enhance the tear trough, which is here. This is another case where you can just see the texture of the skin, and it's flat. I have brought some better projection to the cheek and up here, and the blusher shines and gives a shine to the bit that catches the light. And you can see that the texture of the skin is better. And this has had a lot of Brady buttering, and it's had a deep level placement on the bone. So it's what I call the sandwich technique. And again here, a good texture of skin, but quite flat on the cheek. And here you can see that the light catches it. It's highlighted here, and there's no blusher on, but you've got this shadow, and it makes the face more interesting. And an older person, again, the sandwich technique. I've been working deep. I've been working in the tear trough. Look how I've eliminated the tear trough. A bit of toxin has been used as well to get rid of the lines from the lateral eye, the lateral canthus. We've got a better projection of the cheek. Look, it's like a little pommet, a round apple, as opposed to being flat. And this tissue here, where there's hypertrophy of fat and descent of fat, has been lifted, as you can see here. And then the sandwich technique, that was on the bone. This then is the buttering technique across the rest of the face to build collagen and make it smoother. We must always remember the ethnic background of the patient. This is where I have just augmented some lips for this lady, but she had good lips beforehand, but I did some buttering all the way around here. These are my entry points there and down here, and you can't see any bruises. They perhaps wouldn't show up quite as much, but you know, you've got to be able to consider the different proportions of the ethnic backgrounds. Chins. Look at the interest when you come from here to here. Look at the slope there. Look at the beautiful OG curve falling into the chin. Look at the natural shadow, which is absent here. Look at the texture of the skin on the chin and the orange peel effect here. I did not use toxin here. I just used ultra deep from Teoxane under the muscle. And again here, same patient, jawline, I went in here. We've done the chin, we've brought it forwards, we've stretched out the jawline. We've also brought the jaw into a better definition as well to match the cheek, and they almost go in a parallel line, the jawline to the cheek line. It gives that beautiful, almost like the face becomes a bit of a parallelogram in mathematical terms, and we have a better angle here, and we have that beautiful labio-mental crease. If you don't get the face right from the front, from the profile, I beg your pardon, if you don't get the face right from the profile, you'll never get it right from the front. And this is another chin, you can just see here. It's almost a right angle, 90 degrees. And now it's a beautiful curve. And bear in mind, there's a limit to how much you can augment the lips if the chin is behind. You have to bring that chin forwards to give a little bit more room to augment the lips forwards. It was a nice nose before. It had a little bit of a hooked shape to it, but this does seem to suit her better. This has been a Restylane material placed underneath the muscle onto the bone. And there's no bruising. That was immediately afterwards. It took 30 minutes to do that. It took a long time for the consultation and the planning, but the actual procedure took me no longer than 30 minutes, and that was immediately following. And there is my entry hole right there. This was, I use a cannula in most cases, and you can see the hook shape there and a straighter line there. I didn't have to touch the tip. This patient's very kind. We show a very recent case, and for 20 years she did not like profile. She had a rhinoplasty done by surgery, and it had sunken in too much. She did not like what the surgeon had done, but she didn't dare have any surgery. And she came to me 3 times wanting this doing, and she went away again because she was too nervous. And then finally, in February, she plucked up the courage. And this was the immediate post-op. She's absolutely thrilled, and she's put it on her own Instagram. And that was from a half profile. She almost cried when we finished. I did it by cannula. A little cannula entry point, I think, is there, or it might be here. I can't tell you, but it's one of those 2 places. And that was immediate post-op. And I've had the most wonderful messages from her since. They just keep coming out of the blue. And her nose was rather wide before. A narrower nose is more feminine. And we've given her this beautiful straight chevron. Oh, that's the cannula entry point right there. And we've gone straight down the center, deep under the muscle, and without causing any bruising at all. Very attractive young lady, beautiful face anyway, a mild sulcus on the nose, and she just wanted me to reshape it into a slightly different style. So we don't always have to do a big change. This was a very mild change, and she was absolutely delighted with that. We treat the temporomandibular joint and facial pain and headaches and clenching and grinding and all the symptoms that come from clenching and grinding that break the teeth and crack the teeth and give terrible sensitivity and muscle spasm and pain. We do an occlusal examination. I refer on for restorative work because I no longer work as a restorative dentist, although I used to do a lot of advanced restorative and dental implants, but not any longer. I now work purely in this field, but I do treat in the mouth for this. I provide splints, and I use toxins in the major 4 muscles of mastication, usually in the masseter. This is the type of splint I use. I use 2 types, one that has contact all the way around and one that only has an anterior contact at the front. They have slightly different functions, but I use a splint, and this is worn at night time, and I have worn one for 35 years, and I don't have hypertrophy of my masseter muscles at all. This is another nurse that I had who came to me for pain. She came to me because she felt that her cheeks didn't show, but actually I said to her, it's not your cheeks, it's the fact that you've got enlarged muscles down here. Are you in pain? And she reckoned that her subjective pain level was about 9 out of 10. You can see it in her eyes. She lived with constant headaches, constant joint pain, constant pain down here in the muscles. And every morning she had to unlock her jaw before she could open it. I used toxin and splint, and 6 weeks later, I used more toxin. Another 6 weeks later, so this was at 12 weeks, we have slimmed the face down, and her pain level miraculously went to 0. I saw her, I then later on enhanced her cheeks just in time for her wedding. She's the most beautiful young lady. She's since had 2 children, and I saw her at the other practice about 6 months ago, which was 2.5 years after treating her. And I said, "How are you feeling these days? How is your pain?" And she said, "Honestly, Dr. Ruth, I don't have pain. You just seem to have cured my problem." And she is wearing her splint, and I don't have to do anything to her muscles because they've stayed slim, they've stayed weakened, and she wears a splint at night. So it's been an absolutely wonderful case. This was her from a half profile, and you can see how it's given her a better OG curve on the cheek. This was before I actually did a cheek enhancement, but you can see the pain she's in. The poor girl lived with pain for 10 years, and now she's free of it. So we prefer to make our patients look natural. We like to respect the anatomy. And talking of anatomy, this is Sabrina Shah Desai. She's an oculoplastic surgeon from London who used to work at Moorfields Eye Hospital. And she took it upon herself to find out more about dermal fillers and aesthetic treatments in the non-surgical way, for the simple reason that she was getting a lot of complications referred to her, particularly eye complications. So she went over to America to train, realized the power of the non-surgical treatments in treating particularly the perioral area. And of course, she works all over the face, but the perioral area. And she realized that some of the non-surgical methods were better than the surgery. So she does both and treatment planned patients accordingly. She has received awards for the training course on cadaver heads, which she runs generally at King's College London, and she very kindly invited me on her faculty, so I work with her there. And although there's a lockdown at the moment, although she would be very, very happy to have delegates come over from Egypt and the Middle East to her sessions in London, she has them coming from all over the world already. Because of lockdown at the moment and the problem with flying in, she asked me to mention her virtual reality app, where you can now look in a headset. Now, this is Sabrina modeling the latest eyewear. She looks very fetching. She's a beautiful lady anyway. And this app works through this headgear, and you appear as if you are standing in the room alongside her while she is dissecting. So this is something that may be useful to the Egyptian and Middle East dentists to learn more about anatomy, certainly without flying over for the time being. So that is Sabrina Shah Desai at OFA, standing for Oculofacial Aesthetics Academy. If the treatment has been done well, patients should not look like they've had anything done. If a dentist treats the mouth well, the dental treatment should be invisible, or should I say the teeth should not look as if they have had anything done. They should look like virgin teeth. And it's exactly the same with the face. So if you see people who look strange or their lips are oversized and something doesn't flow, that isn't a good look, and it's not what we intend. Just like we don't want the margins of crowns to show We want to tuck them under the gum or make them blend in to be invisible. We do not want our work to show either. We don't want there to be a start and a finish to it. It should be a very natural flow from one area of the face to the other. And it's all about following the correct facial form. If you don't do that, you will not get a good natural appearance. If you don't get the profile right, you won't get the front of the face right. Please join me on Facebook. I have my page is Dr. Ruth Brady Facial Aesthetics. A lot of my work is also on just Ruth Brady. And this is my Instagram. Please join me on Instagram. I have a lot of videos, particularly in the posts and the saved sections, the favorites, where you can actually watch me doing the buttering technique, and I'm doing lips and enhancing. I'm doing all sorts of procedures, but I'm doing English spoken speakovers over the videos. And that is the end of my presentation right now. And I shall go over to Nory to see if he has any questions from anybody or from himself. Are you there, Nory?
Thank you so much, Dr. Ruth, for this fantastic presentation. Can you hear me well?
Could you speak up a little bit, Nory? You're a little bit quiet. No, I can't.
Better right now?
I can hear you better now, Nory. Thank you.
Okay. First, thank you so much for this fantastic and spectacular presentation. I'm sure that all our audience loved your presentation as much as I did. Actually, there's no questions. There's just one question from Kathy, if I'm pronouncing the name right. She's asking, did you use toxin in Mentalis as well? You probably did. You said in your presentation that you do filler injections in the chin and you do Botox for the Mentalis.
I do. Often when I'm doing a chin augmentation, I find that by putting I go under the muscle with a cannula, and I often find that the pressure of the material, the lift of the muscle, is enough to smooth out the muscle. There are a few cases only where I have actually had to inject a toxin into the mentalis in extreme cases, but I do sometimes on older faces that have an active mentalis muscle and active depressor angula oris muscles. I do actually use the toxin on both those muscles, because I find that if you only do it into the depressor angula oris muscle, then you tend to get a little bit of hyperactivity of the mentalis muscle. And so it starts to become a little bit like orange peel, where maybe it wasn't doing beforehand. So yes, I do in different events. Yes.
I want to know your opinion about something. Actually, it's a kind of recent thing. I guess not all clinicians are familiar with it. The concept of myomodulation, that you can alter the muscle activity without introducing neurotoxins. You can alter its action through a mechanical pressure.
Oh, yes.
So by placing the filler superficial to the muscle, you can also block its action. I have just seen an article, and actually it was published a couple of years ago, that they do injected filler above the elevator muscle of the lip, and they could actually manage to treat the gummy smile. So the filler itself can be sometimes used in special cases as a mechanical blockage for the muscle. Depend on which layer you are placing it. Am I right?
You are very right. I'm not sure if it blocks the muscle action. I've never described it that way. I think the fact that there is more
as a sort of mechanical obstacle, rather than a chemical alteration.
Yes, absolutely, Nory. It's almost a sort of a leverage that sometimes if you have increased the volume or the shape of the tissues, then the muscle, particularly if the muscle has been lifted forwards, perhaps because you've had placement on the bone supraperiosteally, then you get a different pulling vector or a pulling function. And also if you've got more dermal filler placed in the more subdermal tissues as well, then you have definitely got more resistance to action. So it's very important. You've got to understand the movement of the muscles. This is why I think certainly from the UK end, and I'm sure it goes like this across the world because we have delegates coming over, but at dental school, we did not learn dissection in great enough degree. And it was a long time ago. For somebody like me, I was in practice for 30 years. So I qualified in 1981, almost 40 years ago. So I could not remember the fine anatomy from then, and it wasn't even relevant to some of the things we were doing now. So this is why I think this cadaver dissection is such a valuable thing to do at the beginning. And you can actually see where the muscles are working, and you can understand how this myomodulation works. So yes, very much as you were saying.
Okay, Doctor, we do have another question from
Yes.
Dr. Tahani. She is asking, does toxin means Botox? Yeah, it does. Actually, as I told you, here in Egypt, we actually use the name Botox to describe the neurotoxin. But actually, Botox, it's a brand and commercial name. It doesn't mean it is a chemical component. So it's, yeah, the toxin is actually the Botox. Doctor, I was wondering, I actually heard something. I don't know if it's true or not, but after I saw your case, it's obviously true. They do. Does they call you the Queen of Lips in UK?
I'm sorry, Nory, would you repeat the question?
Does they call you the Queen of Lips in back in UK?
Oh, you must have heard that on one of those videos or something. You've got that from Instagram. Well, yes.
I told you, I studied you very well before we did this webinar.
It is a name given in various quarters. The Queen of Lips, yes. I just have a passion. Well, I have a passion for the whole subject. So, yes, I do. I like to do natural lips. I don't like to distort lips at all. I don't tend to get patients coming to me who want strange things doing with their lips that I would think would be strange. I more get patients who they actually tell me that their husbands would get extremely angry if they had anything done with their lips, because they are used to seeing these celebrities on television where the lips have been overlarge, and they don't want their wives to look like that. So I have to do them discreetly, because the woman would like her lips doing, but she doesn't want her husband to notice. So we have to do it incrementally in a build-up, so that sometimes her husband will say, but you don't need your lips doing because they're so beautiful. And the secret is, you see, I've already done them. And the husband doesn't know. And I find that this is often the case, that 90%, I think, around about 90%, probably, it's a guess, of my patients, they don't tell their partners and their husbands, or sometimes the man does not tell his wife or partner. And I've had many occasions where the husband has said to the wife, you do not need treatment because you look beautiful the way you are. And yet that lady could have been my patient for 3 years and he hasn't even noticed that she's had things done, because she's gone home without bruises, and we've gradually built her face into a better form as to look like a younger woman.
Okay, doctor, you also said that you do prefer Restylane Kiss as a filler product to be injected in the lips. But you know well that sometimes some clinicians use Restylane Define as an off-label product for lip augmentation. So, what is your own opinion about this thing?
Oh, I like to use Teoxane Kiss. I like to use
Sorry for interrupting you. Some people also inject Juvederm Voluma to
yes.
give this
Oh, yes. There
passive
are
augmentation, and
there
it lasts longer.
yes,
And it lasts longer.
there are a range of there are a range of products, Nory, from different companies, and although the Galderma, Restylane Kiss, and also, for example, the Teoxane Kiss, they are cross-linked, especially to have some stretch and elasticity in them, to go with the stretch and the elasticity of the lips, the sort of lip movement that occurs. They each have different things in their toolbox, a range of products for different parts of the face. More lifting power, more G prime, more spreadability, more elasticity. So I use Restylane Kiss, but I also use Restylane Define and Refine. I've also, in one case, I used Restylane Volume and had a fantastic appearance. But I do like RHA, Teoxane RHA2 and 3 and Kiss. It depends on what I want to do. Do I want to reshape? Do I want to restore? Do I want to just enhance? Do I just want to refresh? It depends on what I want to do with that patient's lips and what we've agreed that she would want at the consultation. Sorry, Nory, I can't hear you.
Can you hear me well right now?
I can, yes. I've got you again.
Actually, it depends also on the clinician skills. It's not good for a new practitioners to start with injecting Restylane Define in the lips because they may not be able to handle the material properly. Am I right?
Actually, if I was teaching a new somebody that hadn't done very much before, or even none, I would start with a material that was going to give less volume, so that
it could be a more forgiving material.
Absolutely, yes. So I would actually tend to use something like RHA2 or RHA3 or Restylane Refine or Define rather than Kiss, because Kiss gives a little bit more of an enhancement. But having said that, I find that the people that I do train, I've had some superb clinicians. They're not all dentists, but a lot of them have been dentists. They've got fantastic hand control. When I teach them how to hold the cannulas properly, I teach them how to get their body properly balanced, and they do the work with tremendous control. And I'm speaking through it every bit of the time. I've got some of these videos on my Instagram. I'm never worried with these people that I teach. They always end up giving great results. I don't think I've had more than one small bruise on any of the training that we've done, because they're in complete control. So really, Nory, we like to shape the lips as we go along. You were telling me sometimes that you've seen people place it into the lips and then have to use massage to place it into the right places. I like to do it the other way round. We place it precisely. This is precision aesthetics. We place it precisely where we want it. And then I don't even use massage. I just use my thumbs to feel where it's blended. That's all. Almost to confirm that it's in the right place.
Nice. Doctor, do have one last question. One of the things that I have noticed that you are running a one-to-one training. Usually, when courses and workshops are done, there are a lot of number of volunteers who are participating. So I want to know how did you come up with the idea, and do you feel that when you do focus with just the one participant, it will give you a more efficacy and you'll be able
It's
to give more than a lot of number of attendees?
that's a very, very good question, Nory. The fact is that most people start on group courses and there can be 10 delegates or more, even 20 on a course. They come away with insufficient practice and they come away excited but then frustrated. They find that by the time they get a patient to work on, they've forgotten what to do and they've lost their nerve. They've lost they've lost the feeling that they can do it. So I was approached by so many people to say, may I shadow you? So it started with people coming to sit next to me and shadowing. And I found that I accept, I welcomed them in. And then that went on to somebody saying to me, could you teach me privately on my own? So I started with one case just for pleasure. I said, let's see how it goes on this. And it was a friend, one of my daughter's friends, and I did a one-to-one session with her, and she was absolutely flying in the subject after that. Her confidence went up 500%. So that's where it started. She put a testimonial video onto Facebook, telling everybody about her experience, and it started there. So I can't fill all my weekends doing it, but when I get approached, I often actually go to the delegate's own practice with her own patients, and I start at 8 or 9 in the morning, and we work right through, sometimes till 7 o'clock at night. And the difference it makes to their practicing skills, I just can't tell you what a difference. It's immense. And so it gives me...
I know the difference from the beautiful feedbacks I saw on your Instagram page.
Yes.
All the volunteers actually were they very thanking and very encouraging for all other people to participate in this one-to-one training. Doctor, may I ask you further, what is the content? Because I'm thinking of stealing the idea actually and applying it here in Egypt. So what is the content of your one-to-one training?
What are the
content? The content.
The content
of the training.
The content. We normally they've usually done quite a lot of the theory behind, and they've got their certification by going on a training course or two. It's the practical aspect that they are not confident with. So what we tend to do is I tell them to have no more than 3 patients, possibly 4. But we spend about 2.5 hours per patient. We look at the patient, we obviously do the medical history as standard, etc. We then have a consultation that has already generally been done by that delegate on the patient, but we then get the patient in and we analyze the face and we discuss what needs to be done on this face to get the maximum appearance. It's not that we're necessarily going to treat it all in that session, obviously not, but maybe they've come to have their lips done and their perioral, but I take a look at the face and I say, but we can't get those lips right unless we do the chin augmentation first, because the chin is too small. So the delegate sees this problem, the patient sees the reason, and we may do the chin, the perioral, and the lips. And we'll treat a patient slowly, gently, and expertly. and then we move on to the next one. And by the end of the day, my delegates are absolutely, we say, shattered. They are tired out. They are wanting to crawl to bed. And by the time I drive home, I feel the same. Because teaching, I think, is much harder. You've got to have patience, and there's frustration, and you've got to be talking all the time. It's much easier to treat your own patients. It's less tiring. I mean, I love teaching, but it's less tiring to treat your own patients. It's much more tiring when you are watching over somebody else one-to-one, particularly if you've got
I
passion
want to
and they've
interrupt
got.
you for a couple of seconds because actually I'm receiving two comments. One from Helen Eldrick.
Oh,
She is saying
yes.
the one-to-one teaching was incredible, absolute game changer, eternally grateful. And another comment from Zoe Conley, if I'm spelling it right. I
Yes, Zoe
loved my
Conley.
one-to-one training with Ruth. It was an amazing learning experience. You do have a lot of fans, Dr. Ruth, actually.
Well,
They
thanks,
are grateful
Zoe,
for what you
and
do.
thank you, Helen. Do you know, I'm so lucky because I do teach men and women, but I seem to have the most wonderful dentists and nurses who've learned from me. I'm very, very lucky. They are all absolutely budding individuals. They are all going to be fantastic clinicians way after I've retired. And there's method in my madness, Nory. I'm teaching them well because somebody's going to have to look after my face as I get older. So I want to know that they've been taught properly.
This is lovely, Dr. Ruth. One last question. Does this training focuses on the perioral area or you treat the whole face? I mean, they are gonna try to do a neurotoxin forehead, crow's feet, or you focus on the things that is more related to the dentistry? Let's say.
I tend on the first session, I used to concentrate on the lower face to start off with. And then we would do a second, so that I would say, look, just get used to some cannula work, doing the buttering, the Brady buttering, as I call it, on the perioral area, because it's a wonderful place to start getting that technique good. And once you can use the cannulas, and you can use them expertly with great control, you can fly all over the face. Nothing is out of your limit. So I tend to start them off. It's a little bit like you've got a swimming pool. What do you do with a new swimmer? Do you take them in at the shallow end or do you throw them in at the deep end? So I tend to take them in at the shallow end and get their cannula skills good. Once their cannula skills are good and they've had practice, they get me back and we do
Whatever they would like.
mid-face, for example.
Dr. Ruth, thank you so much for your time and thank you so much for this fabulous presentation. It has been a great privilege and honor to have you in my webinar. I hope when all this is over, you'll be able to visit Egypt. You'll actually love the place here. And who knows, maybe you can educate more and more dentists with your immense knowledge. I thank you again and again for your lovely presentation, for your passion, and I learned from you. And I'm sure that all our audience have learned as well as I learned well from you. Thank you so much, Dr. Ruth, for your time. Do you have anything else you want to say?
Thank you, Dr. Nory. I am highly impressed, not only with your passion, but also your knowledge of the subject. There are times in the part one where I would pause for a moment, and I was so delighted because you would come in and finish my sentences, and you would actually put them into the better words than I was going to say it myself, which told me you understood everything I was saying, but you actually understood the concepts behind. I think it's wonderful that from the UK and to the Middle East, we may have a different cultural background, and maybe certain things we would want a slightly different look. But I love the fact that we share the same ideas and passion.
and as you can see, we are much more connected, despite the race and the culture. We do share the same passion. And Dr. Ruth, maybe I didn't tell you this before, but you are someone to look up to as a role model in this facial aesthetic specialty.
Well, that's very kind of you, Nory, and I'm sure by the time you get to halfway to my age, I'm sure that you will fly way past me with your background training, having done a master's in maxillofacial surgery and theses in different things such as the gummy smile. Your academia behind you will surpass anything that I've ever done. I'm very much a practical person, and it's just come from years of practice. By the time that you get in another decade, you will have way surpassed what I'm doing, I'm sure, because time's moving on and things are getting so much more sophisticated all the time. So,
God bless you, Dr. Ruth. Thank you so much. I'm totally honored with your sweet and lovely words of encouragement of yours. Thank you so much again for this webinar, for your time and for your effort. And I hope I can catch you another time, hopefully. Thank you so much, Dr. Ruth.
You are most welcome, Nory. And I have to say to everybody listening, I hope you've enjoyed it, and it's been a complete pleasure. I've enjoyed every minute of it, and I've enjoyed all the presentation that I've been able to put together. Obviously, we've had to keep it to a short presentation today because we have a much wider field in what we do, but it's been worth every minute of the work that I've put in, and I do thank you very much indeed.
Thank you so much, Dr. Ruth, and good night, Dr. Ruth.
Good night, Nory. Good night,
Bye-bye.
everybody.
Bye-bye. Good night.
Good night and sleep well, everybody.
Bye-bye, Dr. Ruth. Bye-bye.
Bye-bye.